The following is a conversation with Gemma Lowery. Gemma is virtual health and healthcare access advocate at ChristianaCare, 22nd largest healthcare provider, headquartered in Newark, Delaware. Gemma is an innovator and an entrepreneur, passionate about clinician and patient experiences. And now, my dear friends, here is Gemma Lowery. My first question for you is a little bit about your current role and how your career journey led you to this role.
Yeah, that's a very interesting conversation. It's interesting to look back on life and realize some of the things you did decades ago actually influenced where you end up now. So a little bit of the backstory for me is I'm currently the technology manager for digital solutions, which is a whole big old mouthful to say that I kind of play a liaison role between IT, use cases, our Center for Virtual Health, and key stakeholders for new projects or innovating old projects. But I kind of got interested. I've always been interested in healthcare. I went to high school fully determined I'm going to go the doctor route, went to college, still going to go the doctor route. Organic chemistry said you're not going to go the doctor route because that was a very difficult course. The labs were great, the classwork not so much. So I did that for a bit and kind of also thought about how many years of schooling that was going to require. And I was at school on a full academic scholarship, and what was that going to look like to go for 8, 10, 12 more years. So I pivoted. I was very, very interested in all things medicine, but also English. I'm a huge reader, huge writer. So switched quickly to English with a business and technical writing degree, and finished on time. Didn't go over my scholarship. Still finished in 4 years. No super senior here, which was great. And then went into banking. Delaware was a big banking state. So I graduated at a time when people were outsourcing all of their writing. And, there was not really anywhere to land. So banking was it. And I got into process improvement and quality there, and then went into manufacturing for a few years because banks were then leaving Delaware, and did that for a few years. And then textiles were leaving the US, going to Asia. So, and then took a few years off with my youngest, and had a friend that was working in HR, honestly, at Christiana, and said, I have this position, it's part-time, nobody wants it. What do you think? And I thought, well, maybe not doctor, maybe I'll go for nursing. So I thought, okay, my kids, all of my kids ended up having some health concerns when they were infants. So I spent a bunch of time, months in and out of the hospital with them with chronic asthma, RSV, pneumonia, and thought it was just insane having to divide which parent goes in, who stays home with the other kids, what do you do, for basically them to get my care and a couple checks a day, from nursing and doctors. So that kind of started the thought of, there's got to be a better way to do this. Not knowing that I would, join the hospital, decide nursing at my age. I did not want to go back to do nursing because that was just brutal. I worked on an ICU as a clerk and discovered telehealth through our virtual ICU. So we had just opened 6 months prior to me getting there. The virtual ICU, I thought this was fascinating because it seemed to check the boxes that I had concerns with as a parent as to why can't I take my child home? Why can't somebody just check on me at home and make sure that we're good? And I, with my writing background, the director needed somebody to help edit his articles. I said, I'll help you edit if you have a job over there for me. So I ended up working over there and went from clerk to operations coordinator, did some administrative and ops work, and was there for years as we innovated and transformed from taking care of people outside of our state to inside of our state, with cameras on the walls to now robots that drive around and check on patients. So a lot of innovation, and it just really piqued my interest, which turned into joining the virtual health team, then the Center for Virtual Health, and then where I am now. So long story to say that you just don't know the things that you're going to stumble across that will ultimately impact you later, and would have given me a real passion about access to care, whether virtually or in person, but in particular virtual after the pandemic.
That's an amazing story because you share different facets of your personality, like as a young person pursuing like opportunities,
then as a mom taking care of her kids, and then as a visionary trying to see, can we do things better in healthcare? And then being given, or I wouldn't say you were given, I think you created an opportunity for yourself to pursue that passion. And it circles back to your like high school years or university years. So I love that story, and thank you for giving it to us. But I wanted to ask about your specific role. What exactly do you get paid to do?
Yeah, that's an interesting question, and you probably get a different answer depending on who you ask. I like to say, at this point, I laugh because I say it's like a chief facilitation officer, if there was such a thing. I think it's what I do is a lot of relationship building. It's a lot of telehealth, subject matter expertise, because I was so close on all levels of the EICU. I also, the University of Delaware started a certified advanced telehealth coordinator course. We were kind of pretty visionary in Delaware with starting telehealth work on a state level. And the university came up with this course, and one of the chapters was the EICU. So I helped the director write the content for that course, and then said, well, if I'm going to do that, I should take the course, so at least I get the credit for it. So then I did that, and then actually ended up teaching the course at UD and becoming their telehealth director and advisor, which was great. And I started joining places outside of the hospital. I joined the Delaware Telehealth Coalition, and I'm a board member for the Mid-Atlantic Telehealth Coalition, Matrix. So these things gave me a purview to what was going on outside of Delaware, because Delaware is a small state. So is this a trend, or is this like really where we're going with the world? And all of those things, I think, helped to make me a SME, a subject matter expert in telehealth, that helped this kind of position grow. It is new. I think before this, I was a virtual health program manager, and then an ops coordinator. And I think it keeps evolving, interestingly enough, with what the expectation is as we get more and more virtual. I think we didn't know what we needed till we needed it. And then we try to quantify it and put it into a job title that fits what you're actually doing. And I think it's probably going to keep evolving. But a lot of it is focusing on the technical piece of the virtual. This isn't the clinical. This isn't so much of the operations, but I have to understand both. It's how do I take what your pain point is, really get into the workflow. What are we trying to do? Are we just trying to replicate in person with tech? Because if we're going to do that, let's blow it up. How can we do something completely different and see if we can really get some efficiencies going? And then have a knowledge of what's out in the marketplace that would be sustainable and not something signed a contract this year and it's outdated next year. Or the company looked good on paper but didn't have any money behind it. Some of the research and the digging so that people don't write these contracts for tech to solve this problem that then end up being a bunch of doorstops later on because they don't function anymore. So I play a lot of translating what the use case needs, what the technical piece needs, where do we need IT, but where do we need something that's really futuristic and maybe is something that's not even to market yet that maybe we partner with. So that's kind of the space that I play in, is really a facilitator that works with stakeholders across the board.
It's an amazing space. And I wanted to stick for just a little bit on this personal story of yours, because you're a woman of color, and you are very different from a lot of even regular white people that I meet in big corporate jobs, because those corporate jobs, they kind of make you fit the fold. And a lot of people stay in their lanes or even silos, not taking the approach that you just described in terms of defining the roles, looking outside, exploring what's there. What advice would you give to someone just starting out in a hospital system? How do you go that journey where you create a job for yourself in an environment that is stacked against this?
Yeah, and I will say it is a in all transparency, it's a lonely space, because they're in the crowd of horses, I'm the only zebra that's running around. I'm the unicorn that's different than everybody else. And people sometimes want to play with you and sometimes not so much, because you're seen as a disruptor. And I think you have to go into this with a really curious mindset. You really have to have a sense of who you are, because it could very easily be something that that just wears you out, that can be really defeating. And you have to be persistent. That's kind of my mantra all the time is persistence. You know, a no is not a no, it's a not now. It's a maybe, it's a come back later, you know, and you have to be somebody that's willing to work on relationships. And you're not going to win at all of them. There's some people that you're just not ever going to get to think the way you do or be open to what you're saying, but you still learn them. So if I learn somebody and I know that this is not something that they're really going to embrace, I'll go to a colleague, I'll go to somebody else that they do have a relationship with and say, hey, how do I present this in a way that this person's going to accept? Or how do I get buy-in from another key stakeholder that's an equivalent to this one so that I can still move forward? And sometimes the answer is no, and you have to be willing to like let things go, which is tough. When you know and you can see that it's something positive that would help people and you can't do it, for me as a fixer, it's tough. It is really tough. And I think time teaches you that you got to go with the things you can actually impact and change and not get completely hung up and devastated by the losses, because they're going to happen. You're never going to be at 100% and you just have to be okay with it. So focus where you really can and learn from what you did that maybe, you know, the things you did that maybe made that relationship harder or helped for the demise of that program. Sometimes it's like, oh, I should have approached it this way. I just didn't know any better. Other times it doesn't matter how I approached it. It was never going to fly because there were external forces that maybe I didn't know about that were influencing the decision. So for me, it's curiosity, it's persistence, it's a thick skin, and educate yourself outside of your system all the time. I'm always partnering outside so that I'm building my brand and my knowledge and what I know and what I know I can bring with full security in what I'm saying, and not just what the siloed information I'm getting from within the system is.
This is awesome, and this is extremely helpful. I might have shared this with you. I'm trying some disruptions with local health systems.
Okay.
And first time we got to one level and it was like shut down for various reasons. The other time it was supposed to start, I got the green light and then the whole team got fired. Like on the day we were supposed to start. So I'm building that thick skin of mine to figure out what's the next iteration. And there are opportunities for sure if you look out for them, but I appreciate you sharing your perspective. So let's go back to telehealth. It looks like you've been in this industry for a number of years. How do you see this industry evolve since you joined it?
Yeah, I've been with the hospital 17 years. So I've been doing telehealth for probably 15 of them. It's really interesting. It's pretty amazing. It was creeping along. We had pretty low engagement. People thought it's funny. They thought it was like the internet. It's a fad. It'll never catch on. Oh my Lord. If you try to take people's internet away now, they die. But it is interesting. It was always kind of that thing you could do if you wanted to, but I don't have to. Besides the ICU where that was the model, there were very few things that we could convince clinicians or other partners to want to take a risk on, because they just saw it as an additional thing to do. They didn't see it as anything that made their job easier. The pandemic, like everybody else, was really what spurned us forward. Our timing was interesting because right prior to the pandemic, we had this big, huge leadership summit, because as the virtual health team, we were struggling with getting people to buy in that this had value. And we said, we can't keep butting our heads against the wall. We've got to figure out what's the spark that's going to get people interested in this. So we had a whole, 30 or 40, the highest leaders we could get in the system, to come together and spend a day and a half just talking about, if there were no barriers, what would you do? What would you do with virtual? And we let people just keep talking and going on. And we captured all of their ideas. And then we said, okay, now sort these ideas down. Let's narrow the scope down. And we just kept working that. And we had one of our chief leaders stand up and say, you know what? Anything that can be done virtually should be, period. That should be our North Star. We are not going to say we're going to fit virtual into what we currently do. We're going to say that we want a target of X, and all of that effort needs to be virtual, because patients, we could all see the writing on the wall. The Amazons, the deliveries, the things people did to bring stuff to their home. it was coming. And we had just had that session. We were deep diving and going through all the data and just setting up meetings to start like picking the top 4 things to dig into, and COVID hit. And it was interesting because one of my vendor partners was with COVID patient number 1 in Seattle. And I remember in January, literally seeing the article and going, wait a minute. And I reached out to them and I said, do you have patient 1? And I don't know if I'm supposed to, but I have relationships with all my vendors. So I just asked. And they were like, yeah, we do. And I said, what do you think? And they're like, it's coming. And I remember going to leadership and saying, we have to pivot. We have to do something. And it took me a couple of months of meetings, literally, for people to say, oh, you might be onto something, and then say, we don't have budget. So I was like, I tried, like I shared it everywhere I could. I said, this is different than Ebola. I really think that we need to be able to figure out a way to get to patients remotely, because this is going to be ugly. And we got the no, there's no budget. And 2 weeks later, everything shut down. So it was interesting. I was glad I trusted my gut because I just really felt like this was coming. But then I watched in a hospital system, the miracle of getting work done in days that would have taken weeks, months, years. Sometimes we just set up everybody that we could send home, we sent home. But my team, IT, legal, we set up a command center in one of the buildings, and we all came to work every day. Like we didn't get sent home. We worked for 4 months solid. We flipped every practice we could to virtual. We knew enough because we were already doing telehealth to make sure it was HIPAA compliant, make sure the tech worked. We were very clear that we trained everybody first. We didn't just hand them a tech bundle. They had to have documentation that they had done training on telepresenting and how to use the tech, not just one, and then provide support as practices went up. But that was where you saw, okay, people are going to have to engage. We're going to be able to get real feedback about, did they like it? Did they not like it? What would they have done differently? So that really changed the whole system. And it actually created where I work now. The Center for Virtual Health is a for-profit wing of a nonprofit hospital, because we kept getting calls from businesses and how do I track my employees? How do I know how do I do COVID tracking? So we started doing that. And then if you have COVID, how do they, they don't have a primary care. So they would join our virtual primary care clinic. We had a long COVID clinic. So we were doing all these things virtually, and we're like, this needs to be different than the main hospital's function. So this kind of evolved into this whole nother business entity. And that changes your buy-in too, because when you're trying to earn money with it, it becomes very different than just because it's the right thing to do. But it laid the foundation for supporting the whole hospital system in what we're doing. So that's, COVID was the game changer, I think, for everybody. I think we lucked out because we weren't brand new when COVID hit. So we had some best practices. We had some SMEs, some people that were just, tipping into it, that I think really helped us move forward in a way that made a ton of sense. And it actually has us, now that the PHE is over, not having to rip everything out and say, okay, now let's do it the right way. Because that's a huge expense when stuff is getting tighter and tighter, and we're not having to do that because we did do it the right way.
Awesome. I love that story. And I love how you mentioned there was an executive from the hospital system who stood up and said, let's do everything virtual that can be done virtual.
Yeah.
To what extent? Is it like 100% being accomplished at ChristianaCare, 90% this vision?
No. It's definitely a work in progress. I think we did kind of what everybody else did. We were at, not at 100% because there were just some practices that just never, they just closed. They just couldn't flip to virtual for whatever reason. But I mean, I'd say we probably did the, 90, 95%, and then dropped down to probably the 30s, and then now the goal is to get back up to like a half and half, like a 50-50 as much as we can. And then, more and more. I think it's hard because we all see the value of it. We saw the access, the people that we got in touch with. The payer landscape is just awful. It is such a barrier because you have all these people that know what to do. They have an idea of why they want to do it. We're stressing value-based care, and the pay modalities are awful, post public health emergency. So how do you do all of this when you've been getting COVID funds and other things helping you for this, 3-year pilot that we all did? And that ends, now we're at the sustainable piece. And that's going to be really, really interesting, because how do you get to those high percentage numbers if your reimbursement rates are actually going down? It's because people still think virtual means cheaper. They don't understand that virtual means tech, means training, people, devices. That all adds up. Now, obviously, in the beginning, it adds up much heavier first, and then you've got a few years where it should start level off. But that initial investment is pretty significant.
I've heard or I came across the term Payvider model. Do you think it could be part of the solution to this perception of virtual being cheap? Like, can providers take on the payer mindset or have to certain degree, or it needs like a bigger solution?
I think it needs a bigger solution, but that's a whole nother conversation about the healthcare industry in the United States. I've got my own thoughts about that. It's to me, it's kind of the money pit that you keep throwing money at instead of burning it down and building it again. And that sounds horrible, because I know that during that burn down time, people would be suffering, but they're suffering now. So I do think that there's going to be a point where I actually think consumerism is going to drive it. I think consumers that have lived for these many years, these past 3 years, getting things whenever they want, how they want, is going to really push, especially health systems. Because if the health systems don't learn to be agile and adapt and morph with the consumers, they're going to go elsewhere. They're going to go to some of these, the Amazons and the Dollar Generals and the CVSs of the world who aren't health first. That's their mandate. They're not a health system. So they have different goals. Not saying that that's wrong, but I do think that people are going to get a rude awakening if they think that going to an Amazon Health is the same as going to your local hospital. I just think there's some things, the equivalencies, that aren't going to happen. When people realize it is going to be the problem, because if they all shift, the hospital systems aren't going to be around at the level that when they realize that there was some buyer's remorse, shifting back might not be as easy.
And do you feel your for-profit arm, is it well positioned to deal with this new reality?
Well, I think it's the system trying to make the best of both worlds, honestly, because, you're going to have the people that come in, you're still always going to have to touch people for some care. You're always going to have to do surgeries. There's just some things you need to be in the space for. But I think not to look at the opportunity for a system to grow without having to buy bricks and mortar out of your state to be able to do it virtually, I think is just really smart. I think more and more systems that look to do that will influence the payer market too, because we're not creating doctors and nurses and clinicians fast enough to keep up with the shortage. So even if people don't want to do it, they're going to have to do it, or we're going to have these humongous health deserts that are going to be devastating. And then you're going to have no option but virtual. So I think by one way or the other, I would love to be proactive and say, we know it's coming, let's get ahead of it. But I'm savvy enough to know that in this industry, a lot of it is reactionary, and it will be when it's bad enough, we'll do it.
I'm a firm believer that innovation usually comes at intersection of different spheres.
Yes.
And I'm particularly passionate about one sphere, which is tech startups that Kepler team typically works with. Yeah. So I wanted to get your perspective on what role do you think tech startups that bring this innovation can play, and what are the typical obstacles they face when they try to engage with bigger organizations such as ChristianaCare?
Yeah, I think tech startups are phenomenal. I think that's where the innovation is happening, because they don't have all the bureaucracy. They're not part of a system that says, take a number, we'll get to you in 2 years. These are the kids that are just doing it. I think tech startups that are really smart actually reach out to hospitals that have innovation centers, or are ones that are actively looking to be part of the transformation, not a recipient of it, because they can give them that real-time feedback. I've gone to sessions where we have an innovation center where we go and some kids or some young startups will come and they'll do like Shark Tank. They'll come and present, we'll hit them with questions, we'll decide if we want to pilot, or we'll kick it back and say, I've seen 12 others, you need to tweak this. I myself, just with my hat, I've talked to other countries and people in other places, either through my course or just, through other associations where they've wanted to say, hey, if I want to get into the US, what do you think? And they've run through their idea and I'm like, you're 3 years late. Like you have to bring something that differentiates you, because if you're just one of what's already out there, you've already lost. Because the cycle of getting into a health system is so long. It is so slow to get through contracting, budgeting, all of that if you're not cutting edge, you're already losing. That's the hook for hospital systems, is you've got to give me something that I can't get in 14 other places, because they're all calling me. So I need to be able to say, no, we've seen all these, but this one is doing something different, and they'll let us partner with its development. I think being able to be a beta partner, doing something where you can actually influence the product, is also really attractive to some of the more innovative systems. And I think that's smart. I mean, on top of the basics, like you've got to have your funding down. You've got to be able to prove that you've got funding going, you're pretty secure, that this isn't all theory and no content.
Could you give, without like breaking any NDAs, some examples of technologies that people come to you with, and you mentioned that they're 3 years behind, or some solutions, and what are some examples that you feel are exactly cutting edge, or where do you see the opportunity for cutting edge innovation?
Yeah, the main ones I think that are behind for me that I've spoken to are RPM companies. They're just jumping in because it's the flavor of the week, because they've heard about the reimbursement. And I actually think it's hurting the RPM option for people, because it's putting so much of a focus on CPT codes and billing that you're losing the actual human value of it and why RPM is so significant. And I think if you come in and you're selling it as, we can do all this work for you and bill the CPT codes, that's fine for the budget guy, the one budget guy that might be on the call. But all the clinical staff and ops people are now annoyed because you didn't do anything to tell them in their day-to-day work how you're helping them get the data that they can act on to now help the patient. And I think that's the thing. And everybody has a platform. Everybody can do the same basic devices, either Bluetooth or some other way. Give me something different. How slimline are you? Are you a patch that can do things no one else can do? Do you have a platform that lets you do RPM and other things? So I don't have to buy 6 different, softwares to get one total look at the patient. I think those are the things, the ability to expand to more than just one use case, I think is really, really significant now. But those are probably the ones I get. Everybody's like, oh, look at this, it's innovative. And I'm like, oh, no, I saw that in 19, it's just old. I'm like, it's really not. And, I'm nice about it. I give feedback, but I will tell people, that's probably going to be a non-starter. So they won't get past me to the team for that. Ones that are really innovative, I think are, like I said, the ones that are the patches, the no contact RPM. I don't need anything. The system actually reads through whatever kind of radar, LiDAR. Yep. And it does the sensing for me. So things that are kind of that, but also you have to have your cybersecurity. You have to, be high trust or something where there's not a huge risk along with your innovation. Because that's one of the first things they'll say is, oh, this is outstanding. Hold up. How much cybersecurity, cyber insurance do you have? And what's the liability? And have you actually, there's just the key things you ask first to find out if a company is FDA cleared or where are they in the process. And, ones that we've been particularly interested in are ones that are flexible and go, we want your feedback to help us build it. That's always really, really interesting. And it's in good faith, it can't be, smoke and mirrors. You actually have to have something to offer. We're not building it for you to go sell to other people, but we have it to this extent, but we only went this far because we want your input. to help tweak it, and then we can co-brand it, we can do something with it. I think all of those are really kind of interesting spaces to be in, because then the risk isn't falling all on one party.
These are amazing insights for tech founders, and I wanted to dig a little bit deeper to understand the actual partnership model. So you want someone a little bit more established with some proper insurance, some funding. Could you talk a little bit about how the process works? Do you like invest in those startups or co-invest in those startups? Should they bring their own funding? Like what's the typical model for an organization to partner with you?
I think just what you mentioned, I think it varies. Honestly, some will involve actual like buying into the company. Other ones will be, if we partner this, there's some kind of sharing on the backside. I think the models can be very diverse, just depending on what the players are each looking for. I think there's always an interest there if there's a way to generate some income out of it, because we've helped self-develop something. But there's a whole team that does that. When that piece comes, I take my side, they go with it and do that and have all their conversations. And I just, listen occasionally. How's it going? But we specifically have folks that will have those conversations with, the venture capitalist team, the other groups that'll get into the details. And the timing is also big. If you have this really, really great idea, it's gotta be, ready to go to market relatively soon. You can't, we've had that. I've had one that came to me and they're kind of like, it's 16 months later and they just got their FDA clearance. Well, it was great to hear about them and I've kind of watched their journey, but that was too long for me to engage. I know about you. That's great. I may circle back once you're there, but for us to have really jumped in 16 months ago would have just been a total waste of our time. And I think it's always respectful to be as transparent as possible and tell people that. Don't string them on. Don't tell them, get back to me in 3 months and you're not going to do anything. So I tend to say pretty clearly, come to me when you hit this point, and then we'll see if there's still an interest, if there's still a use case. It's always in response to a pain point, though. I won't bring tech in just for the sake of it's the next new thing out there. There has to be an associated pain point or you won't get engagement from anybody in the system to want to pursue it. It has to solve a problem for somebody. And if it can solve it for multiple somebodies, that's even better.
And how many of such pilots do you typically or touch or that go through you in a given year?
Not many. There are not many. We may as a system have different groups doing pilots. So we may have 3 or 4 pilots going at a time. The Center for Virtual Health, we are very tied to the budget cycle and what it is that we have to pay to do. We may test things because it's here, test this and let us know what you think. And we have a group that does that. My group will sometimes get involved in that. But it used to be, I think, a little bit more. Now it's harder because staffing is really tight. So it's hard to find people to take on to things that are just pilots. The things that get the really urgent pilot attention are things like virtual nursing, where everyone is struggling. There was no question. It was, we have to have this done. And how fast can you do it? That one we stood up probably in less than 90 days from the ask to when we started, because we had no choice. We were down hundreds of nurses, during the pandemic, everybody did the traveling nurses, but that's not sustainable. That's craziness. So when that ended, how are you helping, the nurses? And how are you creating a better work experience so that the ones we do have aren't burning out and leaving? Because now we're in even a worse situation. So that was one where when the pain point is suffered on a big enough scale by the whole system, those pilots, there's no question. But a new tech that's novel and maybe nobody's heard about, that one's a little bit harder because sometimes the IT resource lift to get both of them working isn't that different. And that can be the barrier is your IT support.
Thank you for mentioning virtual nurses and explaining the whole system. There is one group of companies I'm following, the companies that offer like virtual specialists, like gastroendocrinologists or psychiatrists.
Yep.
Some of them come with technology, some without technology. So from a hospital system perspective, as a telehealth program manager, How do you partner with groups like that based on your experience? What's the right model for the health system and also for startup to speed up and make this partnership truly a win-win?
Yeah, depending on your staffing models and kind of what your availability is to specialty staff. I know as hospital systems, we are very hesitant to want to work with physicians, clinicians, anybody who's not part of our system. We're very, very proprietary of our patients. So we've done this. We did this a few years ago and tried to stand something up where the company brought their own, like, we've got doctors in every state. And we were like, that's great. How do we use ours? Because we could not get over that barrier with the clinicians. They didn't want somebody from 4 states over talking to their patient off hours and possibly changing their care plan, not knowing them. That's a big, big barrier, I think, as we expand across the country and people in all these places grow, that'll change and the fear of that'll change. But right now, I think it's much more, how can I integrate my clinical staff with your technology? How is it making the operations flow easier is the big win. I think holidays and weekends, maybe overnight hours, you might get some buy-in for using using some other staffing model. But it was interesting. We've had vendors come in and say, you have to use ours. That's an almost guarantee that you're going to see the door. And then we've had other ones that say, we have this if you need it. And that approach has gone much, much better. And then it's just the technology just has to be easy for the clinicians. They do not, everybody's more tech savvy 3 years later now, but they do not want anything that's clunky, 17 different sign-ons. I need a different device to do it. They want it to fit into their day and just be, something that becomes part of their routine without a whole bunch of extra effort.
And just to clarify, in terms of virtual nursing, the nurses were external, correct?
No, there are nurses.
So you used just the platform to enable your nurses.
Exactly. Because it was a way to pull nurses that maybe needed to go on light duty. Light duty nursing means you're home. There is no way to be a light duty nurse in the hospital, but your brain is a clinically trained, critical thinking nurse. So if we can find a way to bring you somewhere where you can still use that and you can take some of the administrative burden off, that's a huge win. And we right now are using nurses that they rotate. They spend part of their week on the unit and then the other part virtual. So they know exactly how their unit works. They don't have to figure out like a stranger on the unit what to do. They know what time things happen. They know the temperament of the nurses they're working with, who's going to like it, who's not. And that's been a really big win. As it grows, we know that'll change. You're going to have a pool of nurses and you may or may not have your unit. But for right now, that's working really, really well. And it was probably one of the fastest positives we've ever gotten in a pilot. Within 2 weeks, we already had positive feedback from nurses, doctors, and patients. And that just doesn't normally happen. And that just shows how overloaded they are, on the unit. But we also learned that, you're pulling your staff. The ratios are pretty significant because we don't have nurses, extra nurses to pull from. So we've got to make it something that they feel the benefit of, or they're just going to say, send my nurse back because we're down a set of hands. But it's definitely caught on. We're looking to expand.
I could talk to you for hours. You have so many interesting insights to share, but I wanted to ask about some specific valuable insights that you gained both through your career in telehealth and also in healthcare management that you would like to share.
One of the biggest things is not being afraid to be different, not being afraid to call out things that maybe other people aren't mentioning. I don't look like most people in the room that I'm in. And I will be the one that says, this is great. Innovation is great. Some of these new things are great. We don't live in a really great and equitable healthcare network right now. So all of these things can't make that worse. So social determinants of health, digital literacy, access to the technology, to the devices to then use the technology. All of that stuff has to be part of any work that you do in this space. or you're actually, if do no harm is the mandate for doctors, to me, it's the same mandate for people that are in tech and innovation. You can't do something that's going to cause harm to your patient population or to your caregivers. I think we get the dual sword. We can't have tech that makes it worse for the clinical staff, and we certainly can't have tech that separates us from some of our most vulnerable populations that we're supposed to be mandated to helping. So I actually take it as a charge to figure out how to weave that together and make sure that you're willing to say things that might make people uncomfortable. Is this education that we're throwing at people with the device they've never seen, at 3rd or 5th grade reading level? Does it come in multiple languages? Is there a video in case they don't read it all? What are we doing to make sure that this is the best experience we can make it? Because that's all we can control for everybody that we touch as a system. That's our brand. That's our integrity. That's what we want to be known by. Then we have to make sure that we do the things that maybe would get lost in the excitement of the tech or the challenge of getting it done. We can't do that. Somebody's got to say sometimes, this pilot looks like it's ready to go. We forgot about something, so the pilot stops until we address it. We're not just going to run over people to say we did it.
Awesome. Thank you so much, Gemma. Thank you for your time.
Absolutely. Yes.
Thank you so much for tuning in to this conversation with Gemma Lowery. If you're interested in building something innovative and you need some engineering support, check out Kepler Team, the company that brings you this podcast. And I look forward to engaging with you in the next episode.